Hello. I would like Hello. I would like to welcome you in the session Curative Approaches in Hemoglobin Disorders. I'm Evangelia Yanaki from George Papanikolaou Hospital, and my co-chair, Dr. Sodani, will join us soon. Before I introduce the first speaker, I would like to ask you that you put your questions in the live Q&A button or the discussion forum button next to the live Q&A. So we can now start. Our first speaker is Dr. Suradeh Honjen, Professor of Pediatrics and Chief of Hematology Oncology Department of Pediatrics and Faculty of the Ramaditho Boli Hospital in Mahidol University, Bakong. Dr. Honjeng, uh,
Hi, my name is Suradet Hongyin. I'm the faculty member of Ramadipati Hospital, Mahidol University from Bangkok, Thailand. So the topic of my talk today is haploidentical stem cell transplant in thalassemia with cyclophosphamide post stem cell transplant. So this is my disclosure. I'm the co-founder, shareholder, and a scientific advisor of the Genetic Bio. So it's a stem cell transplant in genetic disease. We, we can categorize in genetic disease in terms of four categories. One is inherited bone marrow failure syndrome. And the second one is inherited metabolic disorder. The third one is primary immunodeficiency. And the fourth one is hemoglobinopathy, such as thalassemia and sickle cell disease. So the problem, the most serious concern in stem cell transplant in genetic disease is graft failure. So stem cell transplant in genetic disease, as I told you, is because of graft failure, the most serious concern. And the most serious concern, this is from two things. The one is hyperactive marrow, and the second one is hyperimmune status. So hemoglobinopathy is ranked number one as a disease of hyperactive marrow because of ineffective erythropoiesis. And the other one is hyperimmune status is because of alloimmunization from the long-term blood transfusion. So that's why I would like to emphasize that in terms of stem cell transplant in hemoglobinopathy, so this kind of disease, the most concern in terms of transplant is graft failure or graft rejection because of two problem is hyperactive marrow and hyperimmune status, as I mentioned to you. So the concept to improve outcomes stem cell transplant in genetic disease, we have to do some kind of pre-transplant management before you're going to jump to do the transplant. And the way how you do the pre-transplant management is try to decrease disease burden, such as in thalassemia in terms of to decrease ineffective erythropoiesis in terms of erythroid expansion, try to decrease that. The second one is decrease alloimmunization. Since have a long-term transfusion, gonna have high alloimmunization. The third one, and try to decrease toxicity. And this is the way we can do by in terms of manipulate or adjust it in terms of conditioning regimen. How are we gonna do decrease disease burden? For example, in terms of hemoglobinopathy, in terms of marrow expansion, we call the ineffective erythropoiesis. This is a normal erythropoiesis compared to the hemoglobinopathy. In terms of ineffective erythropoiesis, gonna have the problem of in terms of high proliferation, high apoptosis, and decrease of differentiation. So this is, for example, the way how we're gonna decrease infective erythropoiesis, such as the targeted therapy. This group of drug like a modulators of erythropoiesis, like a JAK2 inhibitors or activin receptor ligand traps, or luspatercept, and this one, and ruxolitinib of this one. So this is, for example, they have a paper publication from Russia. they tried to investigate efficacy and safety of ruxolitinib in terms of decreased ineffective erythropoiesis before the transplant. 10 patients received ruxolitinib, and then measure the spleen volume has been decreased from 10% to 60%, and the mean volume, the spleen to decrease is 35%. This is the change in spleen volume. And then they have some kind of change in terms of transferrin receptor concentration, and you can see that this is some kind of biomarker of infective erythropoiesis as well. So for 7 of 8 patients underwent stem cell transplant successfully, only one got graft rejection. So we have performed the same thing. 2 patients with beta found hemoglobin E age 21 and 8 years, enlarged spleen and spleen size down to symphysis pubis. Received ruxolitinib for 6 months in the first one and then 1 year in the second one. Spleen size decreased 50% to 60% for each patient, and 2 out of 2 these patients underwent stem cell transplant successfully by doing this methodology. So why do we need haplotransplant? The probability to have match-related and match-unrelated is around 40 to 50%. So half of the patients do not have the donor. So that's why we try to investigate the haplotransplant in this group of patients. The way how we're going to do the haplo, I would say we categorize in terms of graft manipulation in 2 kinds of method. One is this T-cell deplete by cell selection by the magnetic column, or T-cell deplete by cyclophosphamide post-transplant. So for example, for the T-cell depleted by selecting by magnetic column, and this is by the ex vivo T-cell deplete, and try to reduce the graft versus host, especially magnetic column. The first generation is CD34 selection, and the second generation is CD3, CD19, or alpha beta depletion. However, this kind of method is very expensive. This is not including the machine, but in terms of one time, the way how we can do the T-cell depletion is around 30,000 to 50,000 US dollar without any transplantation yet. So that's why we propose the other one by follow the Hopkins regimen in terms of T-cell deplete cyclophosphamide post-transplant. We call this one is in vivo T-cell depletion. And the way how we're going to do, we're going to use the cyclophosphamide post-transplant. This is cheaper. And cyclophosphamide post-transplant, you can see that I think most of us have known already this kind of thing. Give the cyclophosphamide post-stem cell infusion, and this cyclophosphamide gonna get rid of alloreactive T cells, and non-alloreactive T cells gonna persist and engraftment. So this is the way how we're gonna control the graft versus host disease in haploanalytical by using cyclophosphamide post-transplant. The way how we're gonna select the donor, either father or mother who has HLA more than 5 out of 10 matching, no infectious disease like an hepatitis B or C or HIV or syphilis. And most of HLA compatible matched donor, whoever father or mother. And the most important thing, we have to test anti-donor specific antibody in patient developed to either father or not. So we're going to use a father or mother whose the patient did not develop anti-DSA or we call it MFI less than 2,000. The concept I talked to you already, decrease burden at the first time. So right now, how to decrease alloimmunization and decrease toxicity. So we modify the novel conditioning regimen for the non-malignant disease, especially in thalassemia. So this is a novel conditioning regimen for the hemoglobinopathy. With transplant management, I told you already, try to decrease ineffective erythropoiesis, hypertransfusion, ion chelation, hydroxyurea, and ruxolitinib. This is the way how we're going to decrease ineffective erythropoiesis. And the second one, we try to decrease immune status of the patient by giving 2 cycles of the chemotherapy. We call this one is pre-transplant immunosuppression with the fludarabine and dexamethasone, and then 28 days per cycles. And then after 2 doses of Fludex, we're going to give conditioning regimen. This is non-TBI with the peripheral blood, and CD34 is around 7 to 10 cells per kilo. And then conditioning regimen consisted of busulfan, fludarabine, ATG. And this busulfan, we have to do like a dose adjusted with the guided pharmacokinetic study. So after the 2 cycle of fludarabine dexamethasone, we call the pre-transplant management. We try to test T cell function of the patient. You can see after, this is the first one, and this is the second one. And then CD4 proliferation is decreased, zip down to 0 after the 2 cycle of fludarabine dexamethasone. So that's why we call this pre-transplantation cause, we call the pre-transplantation immunosuppression by fludarabine and dexamethasone for 2 cycles. So this is the schematic, the phase 1 flu cycle of fludarabine dexamethasone 2 months before the transplant. And this is 5 days of each drugs. And then the one month later is fludarabine. And the 3rd month, we started conditioning regimen by the upfront ATG, and then fludarabine, busulfans, and then cyclophosphamide on day 3 and day 4. And then this is the ones we have done already in terms of the previous, in terms of the patient who developed anti-DSA, donor-specific antibody. If we want to use that donor, whoever that patient developed anti-DSA, so we have to add the 2 drugs. One is rituximab, and on the day 69, and Velcade on day 64, 60, 63, 61, and this one. And then this is rituximab, and this is Velcade. And then another rituximab again. This is the 2nd dose. And then this is rituximab again. So this is the phase 1, how to control anti-donor specific antibody in terms of patient who develop anti-DSA to the donor. And this is the phase 2, as I mentioned to you already in the previous slides. So the busulfan doses, we give the IV single dose. The age less than 1, we give 80 milligram per square meter. Age 1 to 7, we give 120 milligram per square meter. And then age above than 7, we give 130 milligram. And all single patient, we use the busulfan dose adjusted with the guidance pharmacokinetic. And the AUC total for day is 16,000 milligram per hour per liter. This is that what we try to adjust the AUC in each single patient. So we have published the data, 83 patients in BBMT 2020. In 83 patients, overall survival and event-free survival is 95%. And the oldest patient is 28 years old. So we update as of November 2021, this year, 110 patients. And this to have the same result, 95% overall survival and event-free survival. And the oldest patient changed from 28, and this one 30 years old. In terms of 110, the HLA disparity, you can see that 5 out of 10 matching of high resolution amounts around 72%. 6 out of 10, 14%, and 7 out of 10 is 9%. So this is pretty much haploidentical because most of them is 5, 6, and 7 out of 10 high resolution HLA matching. What about the adverse event effects? In the second, for the 110 patient, acute GvHD around 5% in terms of grade severe, chronic extensive 3%, which is not that bad at all. However, we still have the problem of chronic GvHD mild around 2%, but this is but the time go by is around 1 or 2 years. This chronic GvHD has been gone. VOD around 13%, BO around 3%, graft failure around 3%. And then the most serious problem that what we have in the past, it has been decreased already because in the previous 83%, we got around 30%. But when we increased from 83 to 110 patients, the hemolytic cystitis has been decreased to 20%. So they have low identical. What about in terms of the older age? This is in terms of that haploidentical in terms of high risk and the age group. we call the adult, adolescent, and young adults. We have performed around 18 patients. The age is 15 to 30, and median is 23. And you can see that thalassemia-free survival is 91%. So this is haploidentical in adult and young adolescent, and we got thalassemia-free survival is 91% in 18 patients. Compared to the data, this is from CIBMTR, around 1,110 patients. You can see that the age above than 50 like us are only 62%. And then this is not include haplo, but they call the mismatch relative. I see the data only one antigen, so they got around 70%. So our data, most of the haplo is around 5, 6, and 7 HLA match. We got 95%. And the older age above than 15, and then we got the median age is 23. In our data, we got 91%.
Should I continue?
So the conclusion, our haplotransplant with post-cyclophosphamide thalassemia feasible in all age group, even in adolescent and young adult. And all this, that what we perform is 30 years old. The chronic GvHD hemolysis is mild and is subside in 1 to 2 years. Hemorrhagic cystitis, the most serious problem in the past, and right now is less than the previous reports. I would like to acknowledge of our team of transplant, and I would like to acknowledge our granting in terms of Ramatipudi Foundation. And thank you very much for your attention.
So our next topic will be hematopoietic stem cell transplantation. We will hear India. And our speaker is Dr. Vikram Matthews, Professor of Hematology and Head of Department of Hematology at Christian Medical and Hospital at Vellore, India.
Good afternoon, everybody. I take this opportunity to thank the organizers for inviting me to give this talk and talk about our experience from India on hematopoietic stem cell transplantation for hemoglobin disorders. My name is Vikram Matthews. I'm Professor of Hematology at Department of Hematology at Christian Medical College, Vellore, that's in the south of India. My main areas of interest are hematopoietic stem cell transplantation and myeloid malignancies. Through this talk, I'll talk to you a little bit about the hemoglobin disorders that we see in India and the curative option with allogeneic stem cell transplantation and our experience with this. As seen in this slide, India is a fairly large country with almost 1.3 billion population at this point in time. And the estimated prevalence of thalassemia syndromes is about 100,000, sickle cell disease about 150,000. So very accurate data is not available. It's estimated that almost 3 to 4% of the population are beta thalassemia carriers, and it is estimated that 32,000 children are born each year with serious hemoglobin disorders. There's significant heterogeneity in distribution, as shown in this map over here. The two broad yellow areas represent a band of thalassemia syndromes that are seen in predominantly northern part of the country, and southern part of the country have less incidence of hemoglobin disorders. However, additionally, there are certain pockets, as highlighted here in brown, for example, where we see high incidence of HBS. And there are also small pockets distributed across the country in various indigenous and tribal populations with a high incidence of HBS. There are also some unique patterns of HBD, which is HP Punjab, which is seen in this particular region, and HBE disease, which is seen more in the northeast of India. There are significant challenges in healthcare access, especially for patients with thalassemia major. The per capita percentage of GDP that India spends on public health is 1.2, significantly lower than many of the developed countries. And less than 10% of the population has health insurance. So this is improving with recent schemes that have been introduced in India. Public health system is basic healthcare is its priority, and high-end therapies like allogeneic stem cell transplantation happens predominantly in the private sector, though there are public hospitals and increasing numbers of them that are today offering allogeneic stem cell transplantation. There is a lot of out-of-pocket expense, and the cost of allogeneic stem cell transplantation is prohibitive for many of our patients. There is also challenges with access to centers that perform allogeneic stem cell transplantation regularly. This kind of extreme deformities are now uncommon in the country, but we still have challenges with regular transfusions. There's absence or inadequate chelation in many parts of the country and significant hepatosplenomegaly. This does have implications for patients who do come to us for allogeneic stem cell transplantation because they tend to come to us at an older age with poor prior medical therapy, making them high-risk patients for transplant and transplant outcomes. And allogeneic stem cell transplantation remains the only curative option for patients with thalassemia major at present, so gene therapy is around the corner. The cost of allogeneic stem cell transplantation, MST stands for matched sibling donor, is about $20,000 in the country. A matched unrelated MUD or a matched unrelated donor transplant can go up to $55,000. These are the predominant transplants that are done in the country. Majority are matched sibling donors and some matched unrelated donor transplants. Haplo and cord are recommended only in the setting of a clinical trial. In the recent Government of India, the Ministry of Health and Family Welfare, the Thalassemia Society of India has worked aggressively and with a lot of patient advocacy, has worked with the government to approach companies. And here in this particular case with Coal India Limited, which is a public sector company, and used what's called their corporate social responsibility, where a proportion of their income is spent towards a public utility project. And here they've decided to support thalassemia transplants. About 8 centers are currently supported through this program. Free transplants are offered for eligible patients based on income bracket and age less than 10 years. Close to 150 transplants have been done to date, and a lot of effort has been put by the President and the Secretary, Mr. Deepak Chopra and Mrs. Shobha Thule at the Thalassemia India Society. And Ms. Vinita Srivastava, when she was there with the Ministry of Health and Family Welfare, was instrumental in making this possible. At our center, we have done more than 80 transplants for patients, many of them who would not have been able to afford these patients. And this is a big thank you from all these families to this program spearheaded by Thalassemia India. So stem cell transplantation at Christian Medical College, Vellore, that's my center. We do almost 250 transplants a year. Our transplant program started way back in 1986, and almost 28% of our transplants is thalassemia. Sickle cell anemia is very infrequent because most of the patients in India have a haplotype which is associated with a phenotype which is not as severe as one sees in the African haplotypes. In India, there are approximately now 100 transplant centers. Many of them are small centers, but approximately 300 plus thalassemia transplants per year are done in the country. The risk factors for thalassemia transplant outcomes is a conventional Lucarelli risk stratification, which includes a liver size more than 2 centimeters, presence of liver fibrosis, and inadequate iron chelation. Class 1 and 2 are generally considered low risk. Class 3, which has all these adverse factors, are associated with a high risk. And as I stated earlier, unfortunately, in many of the low middle income countries, including India, patients do tend to predominantly fall into the class 3. The class 3 patients are at a higher incidence of rejection and treatment-related mortality. Novel strategies to try and improve their outcomes are constantly being evaluated by us. So this is the kind of figures. This is data from a large Italian cohort with a very long-term follow-up of what one can expect to see with transplantations. In class 1 and 2, for example, you can anticipate survivals well above 90%, with thalassemia-free survival also reaching 90%. But in class 3, you can see that the survival can drop to 80%, and a predominant number of those patients can actually be alive but have rejected their grafts, and so they're back to thalassemia. And therefore, the thalassemia-free survival is only 58%. Now, when you talk about risk stratification in a country like India, even the so-called class 3 is not really a uniform group. And I'd like to illustrate this by 2 patients over here. Both are by conventional risk stratification class 3. They have liver size more than 2 centimeters. They both have inadequate chelation. One has much more fibrosis. But when you look at additional parameters, one is 14 years, has a spleen size of 5 centimeters. Anybody who's a transplant physician in this audience will straight away recognize that this patient, patient 2, is going to do significantly worse than patient 1. And this is not captured on the current risk stratification strategy. This is something we reported way back in 2007 when we recognized that almost 40 of our patients were even within this class 3, a very high-risk subset, which we subsequently, through a statistical analysis, used age and liver size to identify this subset. So anybody who has an age more than or equals 7 years and a liver size greater than equals 5 centimeters, we call a class 3 high risk. And as you can see in our historical control, survival in this group was so poor that it would probably be unethical to even consider transplant for this population. We evaluated a number of strategies to try and improve the outcome of our class 3 and our class 3 high-risk subset, including targeted dose monitoring, using reduced intensity conditioning. Unfortunately, this was associated with a much higher incidence of rejection. And we finally used a reduced toxicity regimen with triosulfan. Triosulfan is an analog of busulfan, but it has much more linear pharmacokinetics. And what most attracted to us is that it has very little hepatotoxicity compared to busulfan. And in high-risk patients with thalassemia, because of their significant iron load and pre-transplant liver damage, there is a high instance of sinusoidal obstruction syndrome or hepatic toxicity with busulfan. And with triosulfan, this incidence is significantly lower. There was early publication by Franco Locatelli showing very good outcomes using a protocol with triosulfan instead of busulfan. And this is a regimen that we subsequently used in Vellore using thiatripa, triosulfan, and fludarabine. And we've reported our outcomes. This has significantly improved the outcomes. As you can see in this particular slide, this is our class 3 subset. This is the class 3 high risk, this is the overall survival and event-free survival in each group. In the class 3, you can see with the use of triosulfan, the survivals are close to 90% in the class 3, significantly better than a historical control. But what is most dramatic is in the class 3 high-risk group of patients. If you remember the earlier graph that I showed you, with triosulfan, we were now getting more than 86% long-term survival with a fairly low graft rejection rate. Compared to our historical control, this was significant improvement in both thalassemia-free survival and overall survival with the use of a triosulfan-based regimen. So looking at the CMC long-term follow-up, our center's long-term follow-up data, this is very mature data. This is going, as you can see, for almost 264 months. The survival is close to 70%. And if you look at different eras earlier than 2000, between 2000 and 2010, more and greater than 2010, you see the number of patients exponentially increasing. And more important, the age is, they are starting to do older and older patients. And in spite of that, our overall survivals and thalassemia survivals are steadily improving. What about umbilical cord blood transplant? For the most part, this is not done in India. Unrelated match and mismatch is not done. Related cord blood transplants are done randomly at a few centers, but the incidence of graft rejection is high, and generally most transplant physicians in India would not use an umbilical cord blood. Mud transplants are used, but we have limited large data sets to talk about. The outcomes are comparable to matched sibling transplants when you have a fully matched 10 by 10 transplant, HLA matched donor, matched unrelated donor. If you have even a one antigen mismatch at a 9 by 10, the graft rejection rates are significantly higher and the outcomes are significantly lower. At our center, we would not do a matched unrelated donor transplant in thalassemia or sickle for that matter, unless it was a fully matched, a 10 out of 10 fully matched unrelated donor. Moving to sickle cell disease, these are the conventional indications to consider transplant in patients with sickle cell disease, stroke or a CNS event, acute chest syndrome, recurrent veno-occlusive events, impaired neuropsychological function of normal brain MRI, stage 1 or 2 sickle cell disease, sickle nephropathy, bilateral proliferative retinopathy or major visual impairment, and red cell alloimmunization. As I stated right at the beginning, the sickle cell disease phenotype in India, the haplotype that we see in India for the most part is a milder phenotype. And with conventional supportive care, hydroxyurea, and regular monitoring, the frequency of complications is significantly low. So for a majority of patients, we don't feel that there is the indication to consider allogeneic stem cell transplantation for them. In the north of the country, many centers do transplants for sickle cell disease, but many of these are actually patients who come in from Africa with much more significant severe disease types, phenotypes of sickle cell disease. So the anticipated clinical outcomes in patients with sickle disease exceeds 90% the matched sibling donor. However, there can be significant morbidity and some mortality. As I've already alluded to a little earlier, not an allogeneic stem cell transplantation is not for all patients with sickle cell disease, especially for those with a mild phenotype, which we believe is the majority of patients in India. Major early complications post-transplant include a risk of graft rejection, sinusoidal obstruction syndrome, infections, and graft versus host disease. There is a simple risk score that has been recently been described by the CABMTR, which is Central National Bone Marrow Transplant Registry, with data from multiple centers contributing to this analysis. They looked at two cohorts, an initial cohort and a subsequent cohort, where they validated it. And by looking at two parameters, just age at transplant and donor type, a fairly accurate prediction of long-term output could be made in patients with sickle cell disease. And the parameters were essentially age less than or equal to 12 years, and whether you had a matched sibling donor versus an alternative mismatched related or a mud donor. So if you have age less than 12 and you had a matched sibling donor, your outcomes were well above 90%, both in the training cohort and the validation cohort. On the other hand, the green, if you did not have a matched sibling donor, or you had a mismatched related donor or a mud donor with one or two antigen mismatches, the outcomes were significantly inferior. So we would say that you should try and transplant these patients as early as possible, preferably to use a fully matched sibling or a fully matched unrelated donor. So in conclusion, an allogeneic stem cell transplant remains the only widely available curative option for patients with thalassemia major and sickle cell disease in India at this point in time. We strongly recommend to our patients to get transplants done as early as possible, preferably before 7 years of age in thalassemia, and ideally between 2 and 5 years of age. It's not indicated for all patients with sickle cell disease. The conventional risk stratification of thalassemia major has limitations in our population, with many of our patients, more than 60% in our series, being of class 3 high risk. And even within the class 3 high risk, there's a subset which do significantly worse with conventional conditioning regimens. We use triosulfan for this group of patients, and with which we have shown improved outcomes in this high-risk group. The best donor is a match-related sibling. Mismatched unrelated donor and a haploidentical transplant should be done with careful assessment of relative risks and benefits. We actually don't recommend it, and we only recommend doing this in the setting of a clinical trial. The bone marrow is the preferred option as a stem cell source. Novel condition regimens can potentially improve the outcome even in this group of patients. Now, the reduced intensity conditions, most of the data is from the West, where they have shown improved outcomes. In our experience in thalassemia, using a reduced intensity conditioning regimen is associated with a high risk of rejection, and we don't use it. For thalassemia major, we use a reduced toxicity conditioning using triosulfan in place of busulfan. Careful pre-transplant evaluation of the recipient is important. Family and patient need to be carefully counseled about risk benefits of a transplant, remembering that a small proportion of patients we will unfortunately lose due to complications which cannot always be predicted very accurately. Of course, when it goes well, these are all the pictures that I've shown in this talk is with permission from the families. These are families where I only put these pictures up to show mother, father, and 2 siblings. It's almost impossible to make out. These are patients who come to us more than 15 years, 10, 15 years post-transplant. It's impossible to say who's the patient and the donor. This is another family similarly. And we continue to thank all these patients and families who put their trust in us and come to us to undergo this procedure, which is actually quite difficult both for the patient and the family. Thank you for your attention.
Transplantation in thalassemia and sickle cell disease will be presented by Dr. Pietro Sodani, a scientific consultant at Hemato-Oncology Pediatric Session and Bone Marrow Transplantation Unit, Charité Hospital, Berlin, Germany, and Azienda Ospedali Uniti, Martinor, Pesaro, Italy. Dr. Sodani.
Good morning. It's my pleasure to be here this morning Thanks for inviting me. And today I'm going to show to you our retrospective single center study from IME Foundation in Rome. Long-term outcome from CD34 positive to negative depletion approach of CD3 alpha beta T lymphocyte in pediatric patients with hemoglobinopathies. Just a shortly background, the hematopoietic cell transplantation from a matched or unrelated donor remain the only curative therapy for hemoglobinopathies. Approximately 30% of patients have a matched-related donor, and less than 52% of non-European can find a matched unrelated donor. The lack of donor registers and cost of recruiting a related donor make MAT transplant unaffordable for developing countries where many patients with hemoglobinopathies reside. A identical related donor is often available and represent an alternate source of stem cell. We examined the outcome of children with hemoglobinopathies given CD34 positive selection cell or alpha beta CD19 deplete haplo stem cell transplantation. Inclusion criteria were age less than 70 years old, transfusion-dependent thalassemia major, SCA with repeat vaso-occlusive crisis, acute chest syndrome, stroke, or chronic blood transfusion, adequate organ function, lack an HLA match-related or unrelated donor. The first pilot study published in 2010 in 22 thalassemic patients less than 70 years old using the protocol called Protocol 30, the survival rate was 90%, the thalassemia-free survival was 62%, rejection was 27%, no relapse mortality was 10%. We report the results of 54 patients with hemoglobinopathies. And the goal is to compare the outcome of alpha beta T cell displaced patient with the historical group of 40 patients who received CD34 positive selection stem cell. And looking in detail, the group A includes 40 patients, 34 with thalassemia, 6 with SCA. 32 patients received CD34 positive select peripheral stem cell and bone marrow. 8 patients received CD34 select peripheral stem cell and CD3 CD19 deplete bone marrow. Just to simplify, during my talk, I'm going to identify this group as positive group. In the group B include 14 patients, 11 with thalassemia, 3 with SCA. The both group receive alpha beta CD19 deplete peripheral stem cell. And we prefer mother as donor due to maternal fetal tolerance accurate during pregnancy, which is supposed to down-regulate immune responses and induce tolerance to the maternal antigen. The patient received 2 months before the bone marrow transplant hydroxyurea and azathioprine daily, 5 days of fludarabine, and 5 patients received oral busulfan. The other patient received endovenous busulfan, ATG, tiotepa 10 mg, and cyclophosphamide 200. And MMF and cyclosporin and a short course of steroids to prevent graft-versus-host disease. 25 patients received rituximab on days -1 to reduce the risk of ABV lymphoproliferative disease. The cumulative incidence of graft failure in positive group was 42%. In alpha beta group was 14%. I would like just to underline from Marco Andreani report, no association between graft failure and patient disease and treatment related variable. I mean, age, sex, serum ferritin, number of blood transfusion, risk class, splenectomy, busulfan concentration, donor type, HLA mismatch, type of disease, and CD34 cell dose. Our data indicate that the presence of anti-HLA antibody in patient sera, but not donor care characteristic, correlate with the graft failure, thus suggesting that analysis of anti-HLA antibody should be taken into account in transplant setting. The overall survival was 84% in alpha beta group, 78% in positive group. The disease-free survival was 69% in alpha beta, 39% in positive group. The overall survival respect the age at the time of the transplant was 94% in a very young group of patients and 47% in adult patient. I mean patient that which at the time of the transplant was over 10 years. And the disease-free survival was 57% in very young patient, respect 27% in adult patient. The cumulative incidence of graft-versus-host disease, grade 2 to 4, was 29% in positive group, 28% in alpha beta group. Grade 3 to 4 was 9% in positive group, 7% in alpha beta group, and the cumulative incidence of the extensive chronic graft-versus-host disease was 29% in alpha beta group, 10% in positive group. Viral reactivation was common in a BAF group. The incidence of CMV virus, BK, ABV, and adenovirus. The cumulative incidence of ABV-associated lymphoproliferative disease was 60% in all patients, 23% in alpha beta, 40% in CD34 positive group. And I would like to underline the difference of the cumulative incidence of ABV lymphoproliferative disease in the group of patients who did receive rituximab was very low, 4%, respect the patient that did not receive rituximab, that was 26%. Four patients developed autoimmune hemolytic anemia, and one patient autoimmune thrombocytopenia. And only 1 year after their transplant did we identify a partial normalization of CD3, CD4, CD8, and CD19 compartment, determined at different time points. The cause of death was for the almost bacterial or viral infection associated with acute or chronic graft-versus-host disease. And we observed 2 cases affected by lymphoproliferative disease. Here we have 1 case of 1 girl that died after 7 years and a half after bone marrow transplant. She's underwent to splenectomy and she died for sepsis. Our conclusion, haploidentical stem cell transplantation is viable treatment option for selected patients with hemoglobinopathies who lack a suitable donor. CD34 positive select haplo for patients with hemoglobinopathies was associated with high graft failure rate and low disease-free survival. The use of alpha-beta CD19 depleted graft is associated with significantly reduced graft failure in patients with hemoglobinopathies. Viral reactivation and infection complications are frequent. The incidence of lymphoproliferative disease was high in patients who did not receive rituximab prophylaxis. The major challenge of haplo in hemoglobinopathies are delayed immunoreconstitution and associated morbidity and mortality. Now, from some circumstances, I moved from Italy to Germany, and I am a part of Germany consortium in T haploidentical transplant in sickle cell disease. The principal investigator is Professor Selim Gorbashoglu from Regensburg. And currently, the only curative option for sickle cell disease is hematopoietic stem cell transplantation, and the overall survival and the event-free survival following hematopoietic stem cell transplantation from a matched donor are excellent, are really excellent, especially in young patients less than 60 years old. Shortly the background, and I would like to underline this point that the chronic graft-versus-host disease was not acceptable for the majority of the patient. I'm going to describe the results in a first pilot trial, but the pilot trial is actually ongoing in 25 patients. 7 patients underwent transplant for matched sibling donor, 18 patients from haplo donor, and focus in haplo group, 13 patients received CD3 CD19 depleted stem cell, and 5 patients received alpha beta CD19 depleted stem cell. The buff group received almost the same conditioning regimen. ATG, thiotepa 5 mg per kilogram, fludarabine 40 mg per square meter, and triosulfan 14 grams per square meter. And in order to avoid the vaso-occlusive crisis, a partial exchange transfusion was performed. And cyclosporin or tacrolimus and MMF to prevent graft versus host disease. The chimerism of immunosuppression in haplotransplant was 99%, in matched sibling donor was 98%. Incidence of graft versus host disease, acute graft versus host disease grade 1 to 2 was 39% in haplo, 33% in match. None of the patients developed acute graft versus host disease grade 3 to 4. The incidence of chronic graft versus host disease was mild or moderate chronic graft versus host disease in 70% of patients in haplo, 70% of patients in match. The overall survival was 95% in haplo, 100% in match. The disease-free survival 95% in haplo, 100% in match. The toxicity-related mortality was 5% in haplo, 0% in match sibling donor. The conclusion, comparable outcome between match sibling donor and haplo hematopoietic stem cell in patients with advanced stage of sickle cell disease in terms of overall free survival, disease-free survival, and incidence of acute and chronic graft versus host disease. No substantial difference between CD3, CD19, and alpha-beta CD19. Fludara, triosulfan, tiotepa, and ATG is well-tolerated conditioning regimen. Triosulfan has particular advantage in sickle cell hematopoietic stem cell transplantation. Thanks for your attention, and I would like to say thanks to the Department of Pediatric Hemato-Oncology and Stem Cell Transplantation in Regensburg and Pediatric Hemato-Oncology Transplantation Unit in Charity Hospital in Berlin. Thanks a lot for your attention again.
And now we move on to gene therapy topics to hear from two distinguished speakers the advances in the latest developments in gene therapy and gene editing. It's my pleasure and honor to introduce Dr. Franco Locatelli, Professor of Pediatrics at Sapienza, University of Rome, and Head of the Department of Pediatric Hematology and Oncology at Bambino Gesù Children's Hospital in Rome, Italy. Dr. Locatelli will talk on advances in gene therapy by gene addition.
Dear colleagues, it's a great privilege for me to be here today to present the annual TIFF meeting and in particular to address the issue of gene therapy performed through gene addition in thalassemia and sickle cell disease. And these are my disclosures. The last few years have been characterized by the availability of gene therapy and genome editing approaches that represent both potentially curative options for patients with hemoglobinopathies. And what is common to both these strategies is the collection of hematopoietic stem cells that are then selected for being either genetically modified through the transduction of the gene of interest or being treated with approaches allowing the editing of the genes potentially able to interfere with the pathophysiology of disease. And both gene therapy and genome editing have several advantages, but mainly represented by the absence of need for an HLA identical donor. The treatment-associated risks are substantially those typical of a myeloablative autograft with no need of post-infusion immune suppression. And they can be considered also in those patients currently not suitable to receive an allograft. And I am alluding to the late adolescents and the adults in whom the results of allogeneic stem cell transplantation are worse than those observed in the true pediatric population. However, there are also some limitations because they both depends on the use of a chemomyeloablative regimen to destroy the patient's hematopoiesis in a way similar to that of allogeneic transplantation. Thus, they cannot be considered and offered to those patients with a pre-existing severe organ damage, in particular in the liver and in the heart, and considering the limited period of observation, the long-term safety and efficacy remain to be confirmed. What I like to discuss much more in detail is the gene addition therapy, summarizing first of all what we can define as the patient journey, starting with the mobilization of the hematopoietic stem cells through the combination of G-CSF and plerixafor. Once collected through the leukapheresis procedure, the CD34 positive elements can be selected for being then transduced in the case of the two studies on which I like to focus with a self-inactivating lentiviral vector codifying for the T87Q hemoglobin. And once the cells are ready and all the tests documenting the safety of the approach are available, the patient undergo the myeloablation with the use of busulfan, and then the cells are infused intravenously.
Okay,
It's
so I can see me in the preview. That's good.
to draw the attention on the fact that thanks to the substitution at the position 87 of the amino acid that you can see in this cartoon, it is possible to precisely quantify the contribution deriving from the genetically corrected cells to the production of in particular, as I mentioned before, I had the opportunity to participate into the two phase 3 studies of lentiglobin of beta cells. They are the NOSTAR 2 and NOSTAR 3, recruiting patients with a non-beta 0 beta 0 genotype and patients with a beta 0 beta 0 or IDS 110 genotype. In both studies, the primary endpoint was transfusion independence, defined as a weighted average of hemoglobin of at least 9 grams per deciliter without any erythrocyte transfusion for at least 12 months. And in the two studies, 23 and 18 patients were recruited and infused, the median follow-up for both the trials being in the order of 2 years. And since from the phase 1 and 2 trials that were conducted mainly in the United States, it became apparent a correlation between the drug product vector copy number and the peripheral blood vector copy number after the infusion of the genetically modified cells. And the peripheral blood vector copy number correlated with the production of hemoglobin deriving from the genetically modified cells. There has been a refinement in the manufacturing approaches for increasing the vector copy numbers and the percentage of transduced. And these are the patient characteristics at time of enrollment of the 23 and the 18 patients enrolled in the NOSTAR 2 and NOSTAR 3 trial, respectively. You can easily notice that in this patient there is a limited iron overload both in the liver and in the heart, and less than 20% of patients had been splenectomized before receiving the gene addition therapies. And these are the drug product characteristics. You can observe that the vector copy number is in the order of 3, and the percentage of CD34 positive cell transduce approaches 80%. And these values are much better in comparison to those observed in the phase 1 and 2 trial. Indeed, the vector copy number increased from 0.8 to 3, and the percentage of transduced cells from 32 to 78%. All patients had neutrophil and platelet recovery at a median of 25 and 48 days, respectively, and the median time of hospitalization was 40 days. This is certainly the most important slide for addressing the issue of the efficacy of the approach. Indeed, in the 2 studies, 89% of available patients achieve transfusion independence. And it is important also to underline that the weighted average hemoglobin during the period of transfusion independence is in the order of 11.5 gram. But also looking at the few patients who didn't have enough follow-up for reaching the primary endpoint, you can easily appreciate that they are reaching almost all again transfusion independence. And thus we can conclude that roughly 90% of the patients are able to become transfusion-free after the gene addition approaches. And looking at the contribution of the genetically modified cells to the total production of hemoglobin, you can observe that there is a progressive increase till 6 months after the infusion of the drug product, and roughly the quantity of hemoglobin produced by the genetically modified cells is in the order of 9 gram per. Also, the biomarkers of ineffective erythropoiesis and iron overload trend towards normal in patients who achieve transfusion independence. Indeed, you can observe a progressive decline in the serum ferritin levels, as well as a reduction in the soluble transferrin receptor levels, and also the value of erythropoietin decline. Also looking at the histology of the bone marrow, we appreciated a progressive improvement over time. Indeed, from the hypercellular bone marrow observed before the procedure, there is a trend towards an evolution in the sense of reaching either normal cellularity. And also the myeloid to erythroid ratio increase over time, although it is still under the normal values for ratio. The safety profile is consistent with that observed in patients given myeloablative busulfan. In particular, 4 out of the 41 patients develop veno-occlusive disease. It occurred in all patients who were given busulfan as a single dose, while it was never recorded in patients who received the drug in 4 side-divided administration. Remarkably, all cases of VOD resolve with the fibrotype treatment. One patient developed grade 3 cardiac congestive heart failure unrelated to the drug product, which progressively improve and resolve at 12 months. No graft failure, no GVHD, no death occur, as well as we didn't record any replication competent lentivirus, clonal dominance, or malignancies in any of these 4 patients. And concentrating on the pediatric population, the outcome is absolutely superimposable to that observed in the whole population of patients. And in the subset of adolescents, all reach transfusion independence with a weighted average hemoglobin of 11.6 grams per deciliter. The patients enrolled in both phase 1 and 2 and in the 2 phase 3 trials were offered to enter into a long-term follow-up study after the initial 2 years of observation. So we have now the possibility to compare the long-term outcome in these patients. And in particular, so far we have enroll into this long-term follow-up study 51 patients. And as you can observe in this part of the slide, there is a progressive increase in the proportion of patients who reach transfusion independence from the phase 1 to the phase 3 trials. Indeed, 68% of patients enrolled in the phase 1 and 2 study reach transfusion independence as compared to 86% in the patients enrolled in the 207 and 212 trial. And again, you can appreciate the differences in the 2 patient population, in particularly concerning the improvement in the vector copy number and percentage of CD34 transduced cells, thanks to the refinement of the manufacturing process that I was alluding to. And if you compare the hemoglobin in patients reaching transfusion independence, you can easily appreciate that the contribution deriving from the genetically corrected cells increased from 6 grams to 9 grams per deciliter from the phase 1 and 2 study to the 2 phase 3 trials that I commented. And the long-term follow-up investigation also offered us the opportunity to document a progressive decrease in the liver iron content that we observe over time, and which was more evident in those patients with a baseline value greater than 50 milligram per gram of dry weight of liver tissue. And this was reached also thanks to the possibility that some patients had either to restart iron chelation to remove the iron overload or even to phlebotomy. So for the thalassemia part, we can conclude that thanks to this approach, the large majority of patients are able to reach a transfusion independence, and we confirm the safety profile being typical of patients given myeloablation with sickle cell disease is a multi-system disease, as we know very well, and it can be amenable for approaches of gene addition therapy. In particular, the same lentiviral vector that I was already commenting was employed also in the sickle cell disease. You can observe that in the subset of patients treated with the refined manufacturing approach and given myeloablation after the mobilization of hematopoietic stem cells in peripheral blood or use of plerixafor, there is a complete disappearance of the veno-occlusive episode. Looking at the electrophoresis of hemoglobin, you can observe that the T87Q accounted for around 50% of the total hemoglobin. This explaining why these patients are able to become free of any vaso-occlusive complication. And also the median total hemoglobin detected in these patients is above 11 deciliter. Finally, I'd like to touch the issue of the potential insertional mutagenesis associated with the use of lentiviral vectors because these type of vectors are able to strongly reduce the risk of insertional mutagenesis in comparison to viruses. But despite this, there were 2 patients who developed AML in the sickle cell disease program. And in the first patients, no vector was found in the leukemia cells, while in the second case, the vector was detected in blast close to BAM4, which is a gene never reported to be involved in leukemogenesis. So overall, this suggests that probably the leukemia episode observed in the sickle cell disease population is not related to the drug product, but rather to the use of busulfan and maybe to the pre. And also looking at the integration site analysis observed in the thalassemia population, we observe a highly polyclonal appearance, and thus there is no evidence of dominance. So overall, these data are really exciting and confirm the potentiality of representing a curative option for both patients in thalassemia with thalassemia or sickle cell disease. Unfortunately, gene addition therapy could not be available in Europe because the company, the Bluebird Bio, communicated at the beginning of August their decision to discontinue their operations in Europe. And this is the official statement of the company that reflects only the company position. Of course, I hope that in the future the situation will change and we will have this option available for our patients. Thank you for your
And now we move on to the last talk of the session. Advances in gene therapy by genome editing in transfusion-dependent thalassemia and sickle cell disease. And our speaker is Dr. Carsten Lederer, senior scientist at Molecular Genetics Thalassemia Department of Cyprus Institute of Neurology and Genetics, and assistant professor at Cyprus School of Molecular Medicine in Nicosia, Cyprus.
Hello from Cyprus to everyone, and thank you to the TIFF team for the honor of letting me present to you my take on advances in gene therapy by genome editing for transfusion-dependent thalassemias and sickle cell disease. In the following, I will keep technical details to a minimum to convey the bigger picture towards clinical relevance and future prospects. Please feel free to check out the PubMed ID references I give to probe a little deeper in the Q&A immediately after this talk, or to write your questions to me by email. First, I will briefly point out aspects of beta hemoglobinopathies that suggest different gene therapy approaches. Then second, I will give you a primer on established tools, applications, and concerns for genome editing and blood disorders, leading up to third, current clinical trials with focus on results from the CRISPR therapeutics trial. Finally, I will point out some technical developments which to my mind might be instrumental in moving genome editing for beta hemoglobinopathies forward towards greater safety and efficacy. The molecular basis of beta hemoglobinopathies is defects in the production of functional beta globin, suggestive of possible cures. Both beta thalassemia and sickle cell disease are recessive and severe disorders. In beta thalassemia, the absence or reduction of beta globin causes anemia and toxicity by formation of alpha globin homotetramers. This suggests reduction of alpha globin to ameliorate the disease. However, without addressing the anemia, this can only be supportive and not a curative approach. Instead, adding sufficient functional beta globin by gene addition would be curative, as you've just heard in the previous talk. Repair of the causative mutation would potentially restore carrier or normal status given appropriate efficiency. Finally, activation of the beta-like gamma globin would likewise bind excess alpha globin and by formation of HbF restore hemoglobin levels. In sickle cell disease, the underlying beta globin mutation causes toxicity of the resulting beta globin variant itself. In analogy to removal of alpha globin in beta thalassemia, removal of sickle beta globin would only be supportive and would in fact merely turn sickle cell disease into beta thalassemia. However, addition of any anti-sickling beta-like globin, such as Bluebird Bio's T87Q beta globin, the triple anti-sickling Towns beta globin, or even gamma globin, would be curative, as would once again be repair of the causative mutation and activation of the anti-sickling gamma globin. It is important to bear in mind that sickle cell disease is caused by one mutation, whereas beta thalassemia has a great variety of mutations. Here I would like to refer you back to Coralia Stefano's talk on Saturday on our coordination of the variant curation expert panel for hemoglobinopathies. Because mutations can cause disease in the homozygous or compound heterozygous state, therapies universally applicable to all patients represent a logical choice for pharmaceutical companies, so that gene addition and activation of gamma globin are not only potentially curative, but also offer a good return on investment. Nicoletta Papagianou's talk on base editing from Saturday shows our own exciting results in that direction. Arguably, restoring the normal or carrier genotype instead would be a superior option, returning as it does beta globin expression to control under full-length adult regulatory elements, and I will briefly mention some of our own results later. Well, progress in therapeutic editing for beta hemoglobinopathies is based on wider progress in the development of gene editing tools and in their application to hematopoietic stem and progenitor cells for curative treatments. To this end, classic editors identify a target sequence and introduce a double-strand break into the genome as a basis for efficient site-specific modification. Of these, zinc finger nucleases have now reached the clinic for beta hemoglobinopathies, but are difficult and costly to design for new targets. Talifactor nucleases, or TALENs, offer a clear 2 amino acid per nucleotide code and are therefore easier to design, but still time-consuming to clone. Both platforms act as dimers for double-strand cleavage in contrast to CRISPR-Cas-based editors. These are RNA-guided nucleases, or RGNs, as I'll call them later, and rely on Watson-Crick base pairing for target recognition and are almost as easy to design as PCR primers. For cleavage to occur, the so-called guide RNA has to match the target site, while the nuclease protein component Cas imposes the requirement of an additional short sequence, the protospacer adjacent motif, or PAM, which limits the choice of target sites for a given Cas. All three platforms introduce double-strand breaks as basis for editing along two major pathways. Of these, non-homologous end joining allows efficient but imprecise indel formation and is constitutively active in cells, while homology-directed repair, or HDR, uses a donor template with sequence similarity to the target site for precision editing, but is mainly active during the S and G2 phases of the cell cycle, and therefore largely ineffective in quiescent cells. For this reason, the most advanced applications of editing for beta hemoglobinopathies in the clinic rely on non-homologous end joining for editing to allow correction of a sufficiently high proportion of hematopoietic stem cells. These classic DSP-based editors are already being developed into therapeutic tools for clinical application, as shown here for the 2019 R&D pipelines of three major CRISPR-Cas-based companies in one of our reviews. Application to hematopoietic stem cells, and in particular for beta hemoglobinopathies, is prominent here. By the way, I have too little time to mention most of our own lines of research in Cyprus, but should point out to you that I work with a wonderful team of staff and students in our department who perform research on gene addition, delivery methodology, and of course, genome editing. Our most advanced line of research here, which will now move to chimeric mouse models, is that of non-homologous end joining-based disruption of aberrant regulatory elements using TALEN and CRISPR-Cas. In this approach, we address the common beta-globin IBS1 110 splice site mutation by disruption in order to remove aberrant RNA and restore normal beta-globin production. We have shown by transient delivery in primary cells that using either TALEN or CRISPR-Cas RGNs, aberrant RNA can virtually be removed from circulation, so that, for example, beta-globin production, shown in black, is raised to almost the level of alpha-globin, shown in red, and so that across different samples, contribution of beta-globin is significantly restored towards normal levels. In our work, we detected off-target activity of editors, which we have been addressing by new designs, because off-target activity is of great concern. Similar to semi-random gene addition into the genome, off-target activity for editors can lead to insertion immunogenesis. Permanent change in the genome is required for curative treatments, but inadvertent inactivation of tumor suppressor genes or activation of proto-oncogenes has the potential to cause cancer. Be it vector copy number escalation for gene addition, or here prolonged exposure to editing tools as measures to increase efficacy, they reduce safety and may lead to severe adverse SAEs when therapy is applied to a large number of patients. Of relevance here are follow-up data for gene addition by a clinical trial, as shown here for Luca Biasco's clonal follow-up of 2 Wiskott-Aldrich syndrome patients. For month 3 after gene therapy, different HSC clones contribute to blood cell populations, making conceivable that a potentially harmful clone may remain quiescent for prolonged periods to lead to an SAE months or years after gene therapy. In this respect, specific concerns for wide application of DSP-based editing are threefold. First, apoptosis-competent cells may not survive DSP-based on-target editing, so that apoptosis-defective cells may be overrepresented in the resulting cell population, as suggested here in Erie et al. For selective survival of a p53-deficient cell model. Likewise, NHEJ-based side products are hard to predict, and the efficient introduction of a DSP may lead to dangerous recombination events up to chromothripsis. Second, off-target editing can lead to indels and insertion immunogenesis, as discussed, and may moreover amplify the risk for chromosome rearrangements. And third, the currently most widely applied technologies for the assessment of off-target events rely on PCR of likely DSP sites and are therefore blind to larger or recombination events that affect the PCR primer binding sites. For a full picture of events, additional techniques need to be used, such as cast-seq, as shown here for editing of HBB, and for example, prevalent recombination with HBD. Now we get to clinical trials, and the present clinical trials are still based on double-strand break-dependent genome editing and ex vivo application. However, developments here are nevertheless very exciting. At least 5 independent clinical trials are currently registered for beta hemoglobinopathies. A trial announced since 2018 by All Life Medical Science might never come to fruition and offers minimal background information for the people and methods involved. 2 other trials, one on SCD in the US and one on transfusion-dependent thalassemia in China, have been announced, with one of the sites involved in the EdiGene trial already recruiting patients. Two clinical trials are based on Sangamo's zinc finger nuclease technology and address transfusion-dependent thalassemia and sickle cell disease, respectively. The sickle cell disease trial has early follow-up data which indicate that the 3 patients studied had no recurrence of sickle cell disease symptoms. The most substantial follow-up data are available for the CRISPR Therapeutics CTX001 trial, which is part of the company's product pipeline for a range of diseases. The CTX001 trial is split up into 3 trials for transfusion-dependent thalassemia, sickle cell disease, and combined long-term follow-up, respectively. As likely all other trials listed as well, this study is based on disruption of the BCL11A erythroid enhancer using ribonucleoprotein complexes for delivery. The resulting erythroid reduction of BCL11A expression, a repressor of gamma globin, is sufficient to result in therapeutic gamma globin induction. Because of ex vivo application, the trial follows a part centralized procedure where the cells are shipped from the clinical trial site for modification and cryopreservation at the manufacturing site before they are shipped back to the treating doctor for thawing and infusion in the patient. Both the thalassemia CLIMB 111 and the sickle cell disease CLIMB 121 study followed this procedure. For the thalassemia study, follow-up is already available for 15 patients with varying genotypes, including beta 0, IVS1 110, and HPE mutations, while for the sickle cell study, 7 patients have follow-up data. Patients are monitored for adverse and serious adverse events, including events brought about by plerixafor mobilization and busulfan-based conditioning. As of March 2021, for thalassemia follow-up, data for up to 24 months after treatment show stable, high-level HbF expression with above 11 grams per deciliter total hemoglobin from 2 months after treatment. Correspondingly, all patients were transfusion independent at the latest from 2 months after treatment for all genotypes tested. Likewise, SCD patients showed above 20% HbF expression from 2 months after treatment and a total hemoglobin of at least 10 grams per deciliter from 3 months after treatment, with stable long-term HbF levels of above 40% HbF in the absence of vaso-occlusive crises. However, as all current editing trials for beta hemoglobinopathies are based on double-strand break-based editing and size-limited off-target analyses, concerns for long-term safety remain, and also for safety with increasing patient numbers. These concerns have been addressed by a veritable avalanche of innovations for editing molecules and their application. New editing tools are rapidly being developed, for example, towards double-strand break-independent editing, with David Liu's group at Harvard as key innovators. Epigenetic editors sequence-specifically edit the methylation status or transcriptional activity of target loci, which by combination of such editors leads to truly epigenetic, that is, mitotically inheritable changes. Editors can also act on RNA, but owing to the need of the editor to remain present in the cell, this is either not curative for transient delivery or carries the risk typical of gene addition for permanent delivery. The Cas-encoded PAM site renders many potential target sequences unsuitable for editing, and the Kleinsteiber group in particular has been instrumental in finding or developing Cas enzymes with novel or minimal PAM requirements. Base editors introduce precision edits without the need for DSB induction or for an HDR donor, nearly at the efficiency of non-homologous end-joining-based editing. As downsides, effective editing is currently restricted to transition, that is purine to purine or pyrimidine to pyrimidine events, and off-target RNA and DNA editing activity of base editors is still a concern for clinical application, but can be countered by engineering of the deaminase moieties or by encoding it centrally in the nickase Cas9 molecule. Prime editing is a highly flexible, double-strand break-independent editing platform based on incorporation of a reverse transcriptase into the editor and on a PEG RNA that serves both sequence recognition and as primer and template of reverse transcription. This nascent technology was until most recently still plagued by inefficiency and inadvertent double-strand break events, but could, for example, directly revert the transversion event causing sickle cell disease. On a significant aside, CRISPR-Cas-based tools are also emerging in diagnostic approaches that rival the sensitivity of PCR-based tools at reduced analysis times. Well, there are so many innovative studies that it is hard to keep track or make a selection of what is most relevant. My personal pick here, exemplified by 2 studies, are 3 potentially critical developments. First, a base editor with customized PAM requirements has been designed to edit the sickle cell mutation, opening up the door for clinical development of base editors for sickle cell disease. To allow therapy by base editing of a transition event, Lou, Weiss, and their teams focus on converting the sickling mutation to the benign Makassar variant, which allowed substantial correction of sickling cell numbers and beta S expression, and moreover will readily allow tracking of variant expression from edited cells. Second, a study by Lee et al. With involvement by our session chair Evangelia Yanaki exemplified two other potentially critical developments. The study applied both simplex and duplex base editing to induce gamma globin, showing that duplex editing has a synergistic effect for gamma globin positive cells and gamma globin expression levels. Double-strand break independence of base editing now makes such multiplex application of editors possible and potentially safe. Lee et al. Also applied in vivo base editing by mobilization of hematopoietic stem cells and exploiting tropism of the adenoviral vectors used to a human CD46 surface marker expressed in these mice. In vivo application would altogether change the safety and the logistics of clinical editing and is a really exciting development. To summarize currently established editors, we now have a range of tools for curative therapy, as shown here. At present, these all have distinct advantages and disadvantages. DSP-based editors are most efficient for disruption-based therapy, but raise safety concerns, as I highlighted earlier. Base editors are efficient for precision edits and avoid DSPs, but also edit on-target bystander bases, are mostly limited to editing of transition events, and, depending on their protein design, may edit off-target bases in a sequence-independent fashion. Finally, prime editors offer great flexibility and are conceptually DSP-independent and safe, but they still need optimization towards clinical application. As one would expect, all of these editors have already been applied to hemoglobinopathies in proof-of-principle studies, if not in clinical trials. Recent developments outside the field of beta hemoglobinopathies might also massively influence the future of treatments here. Patient conditioning without wholesale chemical myeloablation, for example, would drastically reduce treatment-related adverse events. Two exemplary studies demonstrated efficacy and safety of this approach in mouse models, one using a CD300F pyrrolobenzodiazepine, or for short PBD, antibody drug conjugate in NSG mice, as summarized in this image, the other using a CD117 sapparin drug conjugate in black 6 mice, demonstrating effective subsequent HSC transplantation. Ever since Jennifer Adair's Fanconi anemia trial, close transfection and transduction systems, such as the Miltenyi prodigy, have entered the market for both gene addition and gene editing. In particular for the initial setup cost without the strict need for a cleanroom environment, and regarding the running cost at down to a fifth of what otherwise would be required as staff, this might be a game changer, in particular in low resource settings. Finally, selection of enriched populations of true HSCs, such as CD34 positive, CD38 negative and dim cells, and in particular CD34, CD90 double positive cells, as illustrated here, drastically reduces the required cell numbers and vector material for modification down to a 30th of that needed for CD34 positive cells, meaning a significant reduction in cost and in what are currently limited for GMP reagents. Those and other developments in related fields are really exciting and important to look out for, and will continue to improve efficacy, safety and accessibility of gene editing as therapy for beta hemoglobinopathies. It remains for me to thank my head of department, Marina Kleanthus, my lovely team, and our doctors and patients in Cyprus, without whose samples our primary cell work would not have been possible. I'm also grateful to our collaborators in ongoing projects, such as Mike Antonio at the King's College London and Tony Cutterman at the University of Freiburg, and of course to our funders. Finally, I thank you for your time and look forward to our Q&A session.
I would like to thank all our speakers for this great session. They have presented the current treatment landscape of hemoglobinopathies. And we now start the live Q&A session. I remind the audience to post their questions in the live Q&A button. And I would like to start asking your opinion on, I mean, this goes to everyone, both the transplanters and the gene therapists. Which patients should we consider nowadays for allogenic transplant for from 10 out of 10 matched volunteer donor or an aplo transplant or gene therapy? So who would like to start? Dr. Honjeng, maybe.
About the allogenic transplant in terms of matched
So
siblings.
the question is how, which treatment option you should suggest to your patients.
Okay.
I mean, which, when you would suggest or recommend allogenic transplant from volunteer 10 of 10 matched donor, and when you should consider gene therapy for your patient?
Well, it depends on the budget, and what the gene therapy is right now is not available. And so if in terms of cost of treatment, I prefer in terms of 10 out of 10 match related, all age. If they have a match sibling, right now in Thailand, we do the transplant, even in adult, because we got success almost 100% with our approach. You see, my approach is the pre-transplant immunosuppression for 2 causes, and then guided pharmacokinetic. So we don't have right now. We don't have any single patient die from the transplant in match-related in thalassemia, even in adult.
So I guess even if gene therapy would be available in Thailand, you
We
still
we we,
should
we
consider
have involved
allogenic.
we have involved in terms of we have involved in terms of gene therapy clinical trial in terms of lentivirus. We involve we participate the H in terms of Bluebird bioclinical trial. I think Dr. Locatelli he has mentioned already. Yeah, but right now because the company they don't because in terms of reimbursement it's not clear yet and it's expensive, so that's why it's not available in terms of market. I mean, in terms of the practice. So that's why we just do here.
Actually, yeah, the question was theoretical at this time. Yes, please, Carsten.
So I would perfectly agree with Dr. Hong Yang. I'm sorry if I get the name wrong. So
right.
because of cost, first of all, because as we know, the cost at the moment for gene therapy treatment is extremely expensive. But also because we have long-term follow-up data and really a history of safety for well-matched HLA donors in allogeneic settings, whereas there's still many unknowns in gene therapy. We just recently had, also for gene addition, we had this myelodysplastic syndrome case for adrenal leukodystrophies with an antiviral vector, also from Bluebird Bio. There were problems with that vector and that it has a ubiquitously active promoter, so that it's less safe than the lentiglobin vectors. But still, there are unknowns there that you would avoid if you go for the more traditional approach. Of course, the large proportion of patients that do not have the option of a well-matched donor, they'll have to look. And I think in terms of safety, at some stage, if we really go in vivo, we don't perform myeloablation, then gene editing might be right for the allogeneic transplantation approach, even for well-matched donors. Maybe Dr. Alieri wants to add to this as well.
Yes, I agree with all of you. In the presence of a matched sibling donor, of course, at the moment, this is the preferred option, and we suggest the patient to perform a transplant from a well-matched sibling donor at young age, if available. In the presence of a volunteer donor, the choice is between the degree of match, and we have set usually only 10 out of 10 HLA match donor for patients younger than 14 years of age, or in any case, younger patients. And considering when these options are lacking, it's difficult to find which is the best option for the patient, because each has its own advantages and limitations. In thalassemia patient, data from the gene therapy with lentiviral vector are extremely good, and the safety profile has now been demonstrated. Of course, there are events of myelodysplastic syndrome and myeloid neoplasm in sickle cell disease and adrenoleukodystrophy, but this is not the case of thalassemia so far. And in the future, the great challenge will be to compare this approach and to deliver them in a safe and cost-effective way. And will be a great challenge, especially to compare gene addition strategies and gene editing strategies, because they both are offering extremely promising results in thalassemia, especially in sickle cell disease.
Thank you. We have questions from the audience. So, Dr. Lederer, have any thalassemia major patients that receive gene editing need a transfusion at all post-therapy?
So thank you. That's the question from Maria Hachi Dimitriou. Welcome to the conference. No, so in that respect, the gene editing approach, but patient numbers are more limited now than they were with the gene addition trials by now. But there were, of course, beta 0 cases in as well. So far, all the 15 patients that have follow-up were transfusion independent after 2 months. But of course, transfusion independence is not the only metric. You don't want to change thalassemia major to thalassemia intermediate. So maybe other parameters, when they become available in publication, will be interesting to look at. But for now, it looks like the activation of gamma globin by disruption might be more universally applicable to all patients, including thalassemia major, to achieve transfusion independence. Now, to address maybe a question that has been put by George Constantino in that respect, again, comparing gene addition and gene editing about the affordability. At the moment, it seems to me that because lentiviral vector production is actually more expensive than is the synthetic production of editing tools, it seems that the editing tools are artificially expensive. Because when we write grant applications, for example, the pricing for editing tools is almost the same for GMP level reagents as it is for lentiviral reagents. And I think with time, the cost might drop. So the question was if for low and middle income countries or countries outside the US, there would also be, it would be suitable in terms of cost to apply these approaches. And other things that will contribute would be, for example, in vivo editing, or to go into very young patients where you need less vector amounts. So if you go from 80 kilos in an adult to 4 kilos in an infant, then of course you also drop the cost for the vector enormously. Or if you go in utero, for example. But I think overall reagent cost will drop also once the COVID crisis is over and everything has stopped getting stupidly expensive so rapidly.
So there is a question for Dr. Locatelli. Now Dr. Algeri will respond. Can we expect to see safer alternatives to the busulfan myeloablative conditioning in the future? What would be the approximate cost then for gene addition therapy?
The cost is not related to the busulfan
I agree.
therapy, but it is related to the manufacturing, and it has been anticipated by the previous lecturers also that there are experimental monoclonal antibodies conditioning and immunotoxin that can be tested in the future. Of course, at the moment, the experience is limited to SCID, which is a disorder in which you do not have to destroy an hyperplastic bone marrow with high erythroid hyperplasia. and therefore it can be a challenge to translate this approach in the thalassemia setting. But of course, it is worth to try it in order to increase the safety of the approach and minimize toxicity. This is it, but it won't be impact on the cost. And probably if we use this alternative therapy, the cost may even be higher in terms of cost of the product. And of course,
Yeah, sure.
I see that Karten wants to integrate.
Yeah,
I just wanted to add here, thank you very much. That was exactly, so I perfectly agree, but I just want to add that, these non-busulfan, non-myeloablative reagents like CD300F or CD117, they were just only tested in mice, but if they were to work in human, and it's only a question of time now that they will move to clinical trials, to my mind, then that would be a game changer. Also, of course, for allogeneic transplantation. So all of the adverse events that were observed, most of the adverse events observed both for editing and for the gene addition trials were related to myeloablation and to the busulfan treatment. And so it would really change the safety and the tolerability of the treatments all around. It would be fantastic. Yeah.
So there is another question: how should developing countries? Okay. Because we are running out of time, I would like to thank all the speakers and the audience for this great session. Thank you.
Ευχαριστούμε. Ένας άλλα λέον, Ευαγγελία. Εντάξει, γεια σου.